بداينا. فلنبدأ إن شاء الله بالبيسكس. So بسم الله. As usual, 10 topics. Starting from the first question. 73 years old, gravity 3 by 2 women present with mild abdominal pain and history of amenorrhea. Pregnancy test is positive. Her last menstrual period was 7th of May. She has regular period and she's sure about it. What is the expected date of delivery? كيف نعرف امتى لتولد؟ تمام. فنراجع basic terminology. Gravidity, which is the total number of pregnancy regarded its outcome. Abortion إذا كان البيبي living ولا مو living، إذا كان term أو preterm ما مهم. أهم شيء outcome. أهم شيء إنه في pregnancy كان. And including the current one. والحرف الثاني اللي بنكون هو validity, which is usually 4 numbers. The first number is the term deliveries, يعني اللي بعد 37. الرقم الثاني اللي يكون preterm deliveries. الثالث ليكون number of abortion. الرابع ليكون number of living children. But sometimes they give you only 2 numbers. G numbers, P number. بهذا الحال لتكون الجرافيديتي والرقم الثاني البي، وبعدين الرقم الثاني لتكون الليفينج، بس اللي عايشين هن اللي بنحطهم، يعني مثل هون يعني كان عندها 2 living children. تمام. الهيستوري gestational age by date from the first day of the last menstrual period. when the patient come to us, the question that we should ask is, when was your first day of last menstrual period? Is your period is regular or not? Are you sure about it? Are you sure about the dates? And how the length of your period or your cycle? فعلى حسب الأجوبة بنعرف نحن شو نستخدم. most common method to use is the Naegele's rule. Basically يكون طريقتين. أول طريقة يعني حسابين، بس اللي بتختار اللي بيريحك. first one is the first day of last menstrual period. We will plus 1 year plus 7 days then minus 3 months. أو الطريقة الثانية اللي هي first day of last menstrual period plus 9 months plus 7 days. طريقتين نفس الشيء، بس اللي أريح تستعملها. But it should be the cycle 28 weeks, 28 days. If it's more than 28 weeks, 28 days, we will add the number of the days. اللي أكثر من 28 يعني. If she told you that her normal cycle is 30 days, يعني نضيف يومين. فبدل ما نقول plus 7 days بنقول لا plus 9 days وهيك. But the estimated date of delivery by last menstrual period not reliable if it's irregular or the patient is unsure about her last menstrual about the dates in general. In that case, we will get the dating by the ultrasound. هذا Naegele's rule نستعمله بالميلادي. If it's hearing, we will do last menstrual period, first day of the last menstrual period plus 9 months plus 18 days. First, most probably بالأسئلة بيجي الميلادي فنستعمل Naegele's rule. بس في عنا بعض الحالات لا نستخدم فيها Naegele's rule. We cannot use it. What's the case? If it's irregular, if she unsure about the dates, about her last first day of last menstrual period, or unsure about the length of cycle, about it's irregular or regular, and if there is early pregnancy bleeding, or there is any light bleeding, or if she is using oral contraceptive pill, or if she is breastfeeding, all of that we cannot use Naegele's rule. In that case, we will take the date from the ultrasound. And of course, when the patient come to us, we will take the history, we'll do Naegele's rule if we can, and the ultrasound. Both, we should do both. Yani, ultrasound should be done. Okay, and P6, 1 month, contain 4 weeks, and each complete 3 months, we should add 1 more weeks. لأنه 4 weeks إنه 28 يوم. فبيبقى يومين for 1 month 4 weeks, 2 months 8 weeks, but 3 months will be 13 weeks. So every 3 months we will add 1 week يعني بالcalculation. Ultrasound. Sometimes if we do gestational age by the numbers and or by dating, and we will do after the ultrasound. Sometimes there will be a difference. The patient before 14 weeks, we will measure the crown crown lump length, of course, in the first trimester or first 14 weeks. If it's less than 8 weeks, minus زائد ناقص 5 أيام, it's normal. But it's more than 5 days, that means there's يعني الأرقام خطأ. we will نستخدم الألتراساوند. If it's from 9 weeks to 13 weeks, we will minus, if it's more than 7 days, it's the problem. That means we will reliable on the ultrasound. In second and third trimester, basically بنشوف نحن تطور الفيتس, نموه, if there is any abnormalities and etc. But the dating, it's most in the first trimester. In the fourth, but in the second, third trimester, we will measure the biparital diameter, crown lump, the femoral length, head circumference, abdominal circumference. Okay. So back to the question, what do you think the answer will be? Okay. The answer will be 10th of February next year. لأنه بنستخدم النيجل ثرو لأنه ريجولار وعطاك التاريخ, بس إذا عملت الحسابات لتطلع 14th of February. فحتى يعني لأنه في أشهر لتكون 31 في أشهر لتكون أقل, فلهيك الاختلاف شوي بكم يوم عادي, بس يعني بالأسئلة تكون في اختلاف في الأرقام, فلأنه أقرب شيء هو 10th February فهو الخيار الأضبط. Next question. A 35 years old woman, gravida 2, para 1 at 16 weeks gestational, come to the office for perinatal visit. She reported increased urinary frequency, but otherwise feel well. Pregnancy and delivery of her first child were uncomplicated. Her vital signs and laboratory studies are within normal limits. Pelvic examination shows uterus constant in size with 16 weeks gestational. Which of the following sentence is correct during the pregnancy? As we know, there is endocrine change during pregnancy. So one of the main hormones that change is the progesterone, which is responsible for pregnancy maintenance. It's produced by the corpus luteum within until the 10th to 12th week of the gestational, after which it is produced. Then it's produced by the fetal-placental unit. The other hormone is the human placental lactogenes, which are hormonal synthesized by the cystoturboblasts of the placenta, which promotes the production of insulin-like growth factor. It will increase the insulin level that will cause the hypoglycemia, cause insulin resistance, and the maternal insulin resistance begin at the second trimester and peak in the third trimester. And we have the thyroid hormones. Due to increase the HCG, the TSH will be low during the first part of the first trimester and will be high TBG, thyroid binding glycogen. It will be high. That will lead to increase T4 and T3 and slightly increase in the free T4 and T3 level during the first trimester, and the free T4 and T3 levels decrease during the second and third trimester. And also will be high triglycerides and cholesterol due to increase in the lipolysis and fat utilization and the estrogen. Normally, we have 3 types of estrogen, which is the estradiol, estrone, and estroid. The potency, the normal potency is the estradiol, then the estrogen, then the estrogen. And during pregnancy, the estrogen concentration increase. The estradiol and estrogen is 100-fold increase, but the estradiol is 1,000-fold increase. It is because it's secreted by the placenta as unconjugated estrogen and marker of the fetal health. And when estrogen is bind to its receptor in the cytoplasm, a hormonal receptor complex is formed that is translocated to the nucleus. Okay, moving to the question, which of the sentence you think is the correct one? Okay. Actually, it's the first one, which is the estradiol is the most estrogen type of pregnancy. The estradiol and the estrogen is 100% increase, but the estradiol, this one is 1,000th time increase. Okay, move on to the third question. If you had any question, just write it in the QA part, and after we finish the presentation, we can answer it. Okay, move on to the third question. A 21 years old woman come for the antenatal care visit, 28 weeks, gestational age. You explain to her the physiological change that occur during pregnancy, which is the homological change, cardiovascular change, and etc., to neutralize the developing fetus and prepare the mother for the labor and delivery. What is the homological change would you expect it? Okay. For the homological system, we have anatomical change and functional change. For the anatomical change, because now we have two circulation, the mother and the fetus. So there will be increase in the demand also. So the primary anatomical adaptation for maternal hematological system is a marker increase in plasma volume, red cell volume, and coagulation factors. And the maternal blood volume will be increased 35% by term. So they will be increased by 35%. For the functional change, they will be increased in the oxygen delivery to the lung and the amount of hemoglobin in the blood. So this will result in significant increase in total oxygen carrying capacity due to Bohr effect. And that will increase, and the risk of thromboembolism will double during pregnancy, because the pregnancy considered a hypercoagulated state, and will increase to 5.5 times of the normal risk during the postpartum, and they will be reduced in the hemocrit, especially toward the end of pregnancy, I mean from 30 to 34th weeks of gestational. That will lead to durational anemia, so hemoglobin value will drop below 11. So move on to our question. What do you think the answer will be? Correct, most of you answered the correct answer. Because as we explained before, the blood volume will increase by almost 35%. So it will be, this answer will be D. Okay. Fourth question, at 29 years old, present to your office for preconception and consoling. Her sister recently had a baby with a neural tube defect, and her mother lost a baby due to neural root defect too. Her husband and she are thinking of having a baby, but are afraid that their baby may have a defect. So what is the dose of folic acid that she should take to reduce the risk of neural tube defect? What do you think the answer will be? Okay, let's see. Okay. What is the preconception and consoling? Actually, it's a health education and promotion, risk assessment and intervention before the pregnancy to reduce the chance of poor prenatal outcome. So, the doctor should have a detailed past medical history. This will optimize the medical condition and review medication period the pregnancy. So, and give her some supplementation, mainly the folic acid and iron. If there's any other risk or she have any other disease, we can add something else. Or the medication, change the medication to a medication that can be used during pregnancy. So what are the supplementation? The folic acid. So first, we will encourage the mother to have a diet rich of folic acid and consider supplementation from 8 to 12 week preconceptional to prevent any neural tube defect. And the dose that can be taken is 0.4 milligram or 400 micrograms per day for 3 months before conception, continue to 12 weeks of pregnancy. But if the patients have a risk factor, we will give her 5 milligrams per day. So if there's any previous baby with neural tube defect, or the patient is taking anti-epileptic medication, she's diabetic, or her BMI is more than 35 per kilogram, more than 35, all of that we will give her 5 milligrams instead of 0.4 milligram. And also iron supplementation in case of the patient have iron deficiency anemia. So move on to the question. Okay. Let's first see if she's have the risk factor we said or not. Okay. هل عندها risk factor ولا لا؟ Is she diabetic? No. هل هي كاتبين إن هي obese؟ كمان لا. Okay. Only there is a family history. So we will give her 4 microgram because في family history. Okay. بس في بعض الكتب بحط إنه family history strong family history ممكن نحطه كريسك فاكتور، في بعضهم بيقولوا لا. ف according to some articles will highlight and she's not have a risk factor, so we will give her 4 micro or 400 micro. تمام. Move on to the fifth question. A 22 female patient that has been married for 2 years come to you for preconception visit with a history of 2 pregnancy lost. She tried to conceive, but she didn't succeed. She wants to improve her immunity. What vaccine are appropriate in her case? Okay. Of course, the immunization is so important. So, فبالنسبة للتطعيمات فهن بيوزنوا risk of infection first versus the risk of immunization complication. مثل هلا مثلا الكورونا فيروس الفاكسين تبعه حسبوا انه لو the patient have a COVID during her pregnancy, the outcome will be worse than if she إذا أخذت اللقاح أو لا. فنفس الشيء. فبالنسبة للقاحات بشكل عام في بعض اللقاحات تعتبر safe، في بعض اللقاحات it's better to avoid, and some لقاحات contraindicated to take. The safe is the tetanus, diphtheria, influenza, and hepatitis B, and pertussis. The live vaccines should be avoided because of the risk of placental and fetal infection. What's the live vaccines is the polio, malaise, mumps, rubella, and varicella. The contraindicated vaccine is the oral typhoid. And in general, we should advise the patient to avoid getting pregnant for 4 weeks after receiving any live vaccine. And according to the Public Health Agency of Canada, it's recommended that women who wish to conceive should receive the annual influenza vaccine, and all pregnant women should give the TTAP every pregnancy, irrespective of immunization history. الأغلب بينعطى بين 27 إلى 30 weeks but أحيانا if the patient have high risk of preterm labor نعطيها من 13 ل 26 weeks. But إذا الدي-تاب انعطى في الفيرست trimester يعني قبل ما البيشنت تعرف إن هي حامل مو ضروري نعيده مرة ثانية. So what's the answer will be? Okay, most of أغلبكم جاوب صح. الإنفلونزا مثل ما قلنا varicella live vaccine we should avoid it. rubella بس الإنفلونزا it's يعني بينصحوا إنه تاخد كل pregnancy وحتى بينصح يتاخد كل سنة بشكل عام بس لما تكون حامل أحسن recommended to take the influenza أكثر من agency أحسن إنه تاخد الإنفلونزا. تمام. Move on to the sixth question. A 32 years old newly married come to the clinic because she wants to get pregnant. She has systematic lupus erythematosus, but she's afraid of her medication toxicity and the harm of her baby. What she should do? تمام. بالنسبة لل SLE systematic lupus erythematosus الدراجز بشكل عام تبعها في some drugs that should be avoided, some drugs with small risk of harm فبيشوفوا لو ممكن يغيروها أو لا أو ممكن يبطل. drugs that are safe. The drug that should be avoided لأنه ممكن تعمل birth defects is macrofilate mofetil, cyclophosphamide and methotrexate. Those drugs should be avoided and should be stopped and replaced with other drugs. Drugs with small risk of harm اللي هي non-steroid anti-inflammatory drug, aspirin, prednisolone and azathioprine. Drugs that are safe كل الانتي-malaria drugs consider safe لأنه ما في evidence لأنه هي عملت harm للpatient للmother or the fetus such as the hydrochloroquine. So what she should do? Discontinue the hydroxychloroquine and start cyclophosphamide ولا discontinue prednisone and start MPF ولا شو تعمل؟ Okay, good. Most of you have the correct answer. لأنه مثل ما قلنا hydroxychloroquine الانتي-malaria drug consider safe so نخليها. prednisone كمان يعتبر يعني وسط فممكن نخليه. بس MFF اللي هي contra indication فدغري من وقفها فلهيك نحن وقفنا. تمام. move on to the second question. 38 years old women gravid 2 para 1 comes to the hospital with 40 weeks of pregnancy and she's experienced active labor. When you do a CTG you notice early deceleration. What is the most common cause? Okay. First, let us know what is the CTG. It's a cardiotography, which is one of the most frequent methods used for the assessment of the fetal well-being during pregnancy and labor. It will it will help in the identification of possible harm to the fetus, such as fetal hypoxia and distress, and consists of the continuous recording of the fetal heart rate and maternal uterine contraction. And CTG analysis start with the evaluation of the basics CTG feature with baseline. Basically هو خطين fetal heart rate وتحت لتكون maternal uterine contraction والfetal heart rate هو ففي 4 components لا بنشوفها اللي هي إذا في البيسلاين variability إذا في يعني acceleration or deceleration هو uterine contraction تحت. أوكي. فهذا هو يكون شريط CTG مثل ما شايفين هذا هو تبع الفيتال هارت ريت وهون uterine contraction. فالفيتال هارت ريت مثل ما قلنا في 4 components أول واحد البيسلاين. شو البيسلاين؟ Actually it's the mean level of the most horizontal and least wave of the fetal heart rate segments. Okay. Normally between 110 and 160. Okay. In these patients, as you can see here, it's between 110 and 150 or 60. Yeah. So the mean, if we draw a line, the mean value is almost 130. So it's considered normal. So this is the first component. The second component is the variability, which is the wave in the fetal heart rate signals that evaluate as the average bandwidth amplitude of the signal in 1 minute segments. So ولازم نعرف إنه هذا الخط يعتبر 13 seconds. ف one small square 15 ثانية وهذا 5 beat per minute الامبليتيود تبعه 5. فالسمول بوكس عرضه لتكون 15 seconds بهذا بس، فهذا 13 وهذا يكون 5. فمثلا لو مسكنا هذا نشوف الفاريابيلتي تبعه، شوفوا أكثر من 1 بوكس فيعطي أكثر من 5 يعني تقريبا 10 فيعتبر نورمال. في variability فالبيسلاين هو 130 which is normal within normal range, and the variability which is, as we say, it's almost 10, so it's normal. The third component is acceleration, which is increase in the fetal heart rate above the baseline for more than 15 beats per minute in amplitude and lasting more than 15 seconds but less than 10 minutes. مثل ما هون شايفين احنا. فلو شفنا البيسلاين كمان it's almost 130 واكسلريشن فوق. فلو شفنا مربعين 3 almost 15 more than 15 ولast one more than 15 seconds كمان. ف it's normal. And for the deacceleration في عنا 3 أنواع early, late and V shape. ف deacceleration ال early one are slow, short lasting وهو due to fetal head compression. فلو تلاحظوا هو مع uterine contraction، هذا هو الخط ما قلنا تبع uterine contraction. فهون صار في deacceleration مع uterine contraction، هذا بلش هون بلش هون انتهى هون انتهى، فهنا مع بعض. هذا بنسميه early deacceleration and it's due to fetal head compression. The late one غير شوي. The contraction are frequency the contraction start more than 20 seconds after the onset of the contraction and it's due to chemoreceptor mediated due to fetal hypoxia. مثل ما هون شايفين هون انتهى الكونتراكشن شوي بعدين صار deacceleration. هذا الفرق بين early والlate. early due to or fetal movement fetal head compression بس بالlate is due to fetal hypoxia for more serious. الليت early ممكن normal يعتبر بس الليت هو pathological or need action. And the third one is the V-shaped. It's the acceleration that exhibit rapid drop. It's less than 30 seconds. It's a good variability within the deacceleration. There will be rapid recovery to the baseline, and they will be varying in size, shape, and relation to the uterine contraction. مثل ما شايفين ما في أي علاقة مع uterine contraction. هون في uterine contraction بس ما في هون deacceleration. ولما ما يكون في علاقة هو في shape وفي مثل V هو V shape. إذا واحد يعني خلص uterine contraction أول ما خلص بدأ deacceleration نقول late. إذا الcontraction مع deacceleration early. Okay, the acceleration constitute the majority of the deacceleration during labor, and they translate a baroreceptor mediated response to increase the arterial pressure as occur with umbilical cord compression. فالearly كان fetal head or fetal movement. اللate كان fetal hypoxia. V shape or variable deacceleration can due to umbilical cord compression. So here we notice early deacceleration. What's the most common cause? Okay, most of you answer correctly. لأنه fetal head compression بيعمل early deacceleration. Umbilical cord compression, it's due to V, variable deacceleration. Placenta insufficiency, late deacceleration. Correct? This time CTG, a 30 years old primary para with an uncomplicated pregnancy goes into the spontaneous labor. At 39 weeks, the CTG shows fetus that is due to cord compression. What will be? As we say in other previous slides, the early deacceleration is due to compression of the head. And for the what we will do for it, it's if it's normal. So normally there will be no fetal distress. Late deacceleration is due to uteroplacenta insufficiency, and it will lead to fetal hypoxia and acidosis. We will do intrauterine resuscitation, and another slide we will know how we will do this resuscitation. If after this resuscitation, the fetal heart rate doesn't improve, we will do emergency C-section. If it's improved, okay. If it's not improved, emergency C-section, C-delivery. For the variable deacceleration, is due to umbilical cord compression. It's the same. If we will do intrauterine, if it's okay, and we have two types. If the intrauterine variable deacceleration less than 50% of the contraction, so there will be no intrauterine intervention are needed. But if there is recurrent variable deacceleration more than 15% of the contraction, in that case we will intervene. So we will do intrauterine resuscitation. If it's not improved, we will do emergency C-section. So what is the answer will be? Correct, most of you answered the correct answer. So the cord compression, there will be variable deacceleration. The early deacceleration will be due to fetal head or the fetal movement. Late deacceleration, placenta insufficiency. Okay, move on to the 9th question. A healthy 30 years old, Gravita 1, para 0, presented to her local hospital at 40 weeks, complaining of lower abdominal pain, reduced fetal movement, and spontaneous labor. Her pulse and blood pressure are normal. She is in labor. During the second stage of labor, her CTC show late deacceleration. What to do? Actually, late deacceleration have many causes. So excessive uterine activity is the most frequent cause of fetal hypoxia acidosis, and it can be detected by documenting tachysystole, which is more than 5. Tachysystole in the CTG tracing and or palpating the uterine fundus. And during the second stage of labor, maternal pushing efforts can also contribute to fetal hypoxia or acidosis, and the mother can be asked to stop pushing until the situation is reversed. And if there is any orthocaval compression can occur if there's in the supine position, and this will lead to reduce the placental perfusion. So excessive uterine activity may also be associated with a supine position, possibly due to the stimulation of the sacral plexus by the uterine weight. In that case, we will turn the mother to her side. So frequency followed by normalized of CTG pattern. And sudden maternal hypotension can also occur during labor because many factors, maybe due to blood loss, and usually also after the epidural or spinal analgesia. Sudden maternal hypotension can also occur, and it's usually reversed by rapid fluid administration or an intravenous epinephrine bolus. So there is many factors or many causes that can cause it. So if the patient is giving or taking epidural anesthesia, that will lead to prolonged deacceleration. If there is any fetal bradycardia, also that will lead to prolonged deacceleration. If the patient is taking magnesium sulfate, there will be decreased variability. And if the patient is taking oxytocin, it will lead to late deacceleration. And in case of cord compression, variable deacceleration. And if the head is compressed or inappropriate position, it will lead to early deacceleration. The placental insufficiency or abruption can lead also to early deacceleration. Sinusoidal pattern in CTG, usually due to fetal anemia. And if we found a flat fetal heart in CTG, we immediately should stop the magnesium sulfate because usually it's due to the magnesium sulfate. And if there is any, we found fetal bradycardia in CTG after the preterm rupture of membrane, in case of polyhydrops, that mostly due to cord prolapse. So what we will do if we saw a late deacceleration? First, we will change the position of the mother. If it's unchanged, we will give her oxygen. If it's unchanged, empty the bladder. Then stop the oxytocin. If it's not work, we will do amnio infusion. If it's not work, we will give her terbinafine. And if she's in the second stage of labor, and all of that is not working, and she's in the second stage of labor, we will deliver her by instrumental vaginal delivery. And if she's in the first stage, we will deliver her by cesarean section. So it's يعني بنبدا بالchanging position. إذا ما اشتغل بنقول نعطي أكسجين. إذا ما اشتغل empty the bladder هيك يعني. So in our case, what we will do? And she's in labor, second stage, and the CTG late deacceleration. What first step to do? Okay, great. Most of you. 83% ممكن جواب صح. Change mother position. إذا ما اشتغل we will give her oxygen. إذا ما اشتغل empty the bladder. بعدين oxytocin. فهو بالترتيب. فأسهل واحدة change mother position. أول واحدة يعني. Last question. 23 years old female for postpartum come to you for postpartum contraceptive counseling. She's delivered spontaneous vaginal delivery 2 weeks ago and now breastfeeding. After reviewing her history and physical examination, what contraceptive method is best for her? So she's postpartum from 2 weeks and she's breastfeeding. Okay. For family planning or contraceptive, we have the combined oral contraceptive. We will give her within 5 days of the menstrual cycle, but the oral contraceptive, combined oral contraceptive need additional contraceptive for 7 days if it started at other times. And in case of postpartum, we will start it on day 21, but not breastfeeding. Actually, breastfeeding is considered absolute contraindication in combined oral contraceptive. So after 6 months of fully breastfeeding, it can be. So after 6 months, okay. But if it's breastfeeding, still breastfeeding, we cannot. And another absolute contraindication is breast cancer, active liver disease, past history of CFA. If there is any malignant hypertension, also is absolute contraindication. For the relative contraindication, if she's smoker, more than 35, also is relative contraindication. For the progesterone only pill is to start on day 1 of the cycle, not like the combined oral contraceptive, which start from first day. And in progesterone only pills, we take only 1 pill every day, and it can be started up to include day 5 of menstrual cycle without need of additional contraceptive. And it can be started up and including day 21 postpartum. So postpartum, which is postpartum, newly postpartum, we will give a progesterone only pill. And can be started within 5 days of termination of pregnancy, of miscarriage, and it can be continued up to age 55 years if there's no contraindication. What is the contraindication? If the patient have allergy, progestin allergy, if she have irregular menstrual history, if she has past history of ectopic pregnancy, also we cannot give her progestin only pills. Progesterone only implants or injection. It's ideal in the first 5 days of cycle with no additional contraceptive, unlike the contraceptive that need additional pills. It can be given at any other time, providing the woman is not pregnant. So if she's pregnant, of course, we cannot give her. Postpartum, after 4 weeks, and can be started within 5 days of termination of pregnancy or miscarriage, but it have a serious side effects. So it will be weight gain, mood change, headache, and osteoporosis in some cases, and delay fertility 9 months after stop it, which is the main side effect for the Mirena, which is okay. It can be inserted anytime within the first 5 days of menstrual cycle. It can be started at any other time, provided the woman is not pregnant, or postpartum after 4 weeks. And in it, we can give it post-abortion of miscarriage within 2 days, or delay until 4 weeks. But the advantage of it, it can be given within 2 days post-abortion or miscarriage. So in our case, what we will give them? She's postpartum, 2 weeks postpartum, and she's breastfeeding.